afternoon, everyone, and welcome to the QSource QIO Office Hours, Infection Control, Getting Back to Basics. My name is Tammy Geltmaker, Program Director for QSource. Our agenda today includes opening remarks, our featured presentation, an opportunity for questions and answers, and closing remarks. Before we begin, we'd like to take just a moment to tell you about our organization. QSource has more than 45 years of experience working with healthcare providers, Medicare and Medicaid, and currently operates in 11 states overseeing end-stage renal disease, external quality review, and QIO activities. And of course, as you know, QSource is the Quality Innovation Network Quality Improvement Organization, or QIO for Indiana. We convene, teach, and inform healthcare providers, engage and empower patients, and inspire the entire healthcare continuum by sharing knowledge and spreading best practices. Thank you for taking time to join us. We appreciate all that you do to improve quality and achieve better outcomes in health and healthcare and at lower cost for the patients and communities we serve. Today's office hour is one of several webinars hosted at QSource. Each office hour is made available for on-demand learning to share with your peers. Today's presentation will be made available as well. Before we begin, I want to run through a few housekeeping items. We have the phone lines muted at this time, and we will not be opening the phone lines on today's webinar. However, we do have the chat function, question chat feature. The question chat box is located on the right side of your screen. Teresa Hostetler will be monitoring the chat feature as we move through the presentation today. So if you have a question or a comment, you can post it in chat, and we will respond to you either in chat or on the call. We do ask that you please monitor the chat function frequently for information or questions from the moderator. It is my pleasure to introduce today's speaker, Kara Dawson. Ms. Dawson is a registered nurse with over 25 years of nursing experience. She started her career as a CNA before pursuing her bachelor's degree in nursing. She has both acute and post-care experience. During her acute care experience, she worked in various areas of the hospital, including the dialysis unit, critical care, neonatal intensive care, labor and delivery, and postpartum. She entered the long-term care setting where she fell in love with the residents and their families, and she remained in this setting for over 20 years. During her time in long-term care, she worked as a staff nurse, unit manager, facility educator, and scheduler, an MDS coordinator, which she still maintains that certification, and director of nursing. She is currently working for QSource, the Quality Improvement Organization for Indiana, as well as pursuing her master's degree in healthcare administration. Without further ado, I will turn it over to Ms. Dawson.
Thank you so much, Tammy, and thank you everyone for joining us today. As Tammy said, this is going to be a back to the basics infection control overview. It's going to focus on nursing, dietary, and housekeeping. We'll do an overview of COVID-19 and those color zones, as well as a review of the focus survey, and then some available resources that we have for you. To start off today, I think it's important just to talk about standard precautions. As we know, all persons are a potential source of infection at all times. So we utilize and we practice standard precautions with all of our residents at all times. Standard precautions include hand hygiene, so either washing your hands with soap and water or using an alcohol-based hand sanitizer. That should be done before and after patient contact and after contact with the immediate patient care environment. Personal protective equipment, so we use that when we know we're going to have an exposure to blood, bodily fluid excretions, or just when we're going to have that patient contact, we would wear gloves at all times. Standard precautions are something that we should use all of the time, regardless of the resident's diagnoses. The fundamentals of standard precautions we know pertain to every department within our facilities. So it goes from linen and laundry, trash, biohazard, waste sharps, to environmental cleaning and resident care equipment. Hand hygiene, as we know, is what how many infections are transmitted. And hand hygiene is the #1 way that we can prevent the spread of infection within our facilities. So that sounds easy enough, and we all know how to wash our hands. But what we find in the data is that healthcare personnel practice hand hygiene only about half of the time that they should. So hand hygiene most often gets missed either right before we do patient care, as we're leaving the resident's environment, or if we go into a resident room and we're not going to do any resident care, but the resident asks us to them their call light. They've asked us to move their bedside table over to them. We've touched their bed rail, or even in housekeeping, if you're taking in their laundry back, giving it back to them, and you're opening up their closet just to hang their laundry up, that is touching that resident environment. And so what our surveyors are looking for is that we're washing our hands after we leave that resident care area. After removing gloves, we're seeing a lot of citations right now about no hand hygiene in between glove changes. So making sure that when you're going from a dirty part of a procedure to a clean part of a procedure, or you're changing your gloves during peri-care or during a bath or a shower, that you're doing hand hygiene in between those glove changes. The other time that we're seeing is going into the resident room. That's the first thing you should do before entering into the resident room is hand hygiene. It's the last thing you do when you walk out of their environment or out of their room. When you're walking into the room, making sure that you don't put your hand in the glove box before you do hand hygiene. So we're seeing citations, people put their hands in the glove box, they get their gloves out, they're doing their hand hygiene, and then they're putting on their gloves. If that happens and you realize, oops, I just put my hand in the glove box, that box of gloves technically is contaminated now because you put your hand in that glove box before you did hand hygiene. So you need to get rid of the box of gloves, get a new box of gloves, do hand hygiene, then get your gloves and put your gloves on. Hand hygiene obviously needs to be performed before having contact with residents, before you're putting on those gloves, inserting any devices in between each meal tray. When you are assisting in the dining room during mealtime, or you're passing trays in the hallway, now that we're not doing that communal dining anymore. I know that some facilities are now doing half of their residents go to the dining room at one time and then the other half come at a different time. But if you're still, if the residents are still eating in their rooms, you still need to perform hand hygiene in between each resident meal tray. So either soap and water or alcohol-based hand sanitizer. And before, during, and after preparing a food. We talked about that it needs to be performed after you're having contact with the resident's skin, after contact with any environmental surface, and after removing your gloves, or whenever your hands are visibly dirty or contaminated. Remember, washing your hands first thing when you go into the resident care environment and the last thing you do when you leave their room. If you have doubt, should I wash my hands right now? I encourage you just to wash your hands. They cannot cite you for washing your hands too many times, but they will certainly cite you if you don't wash them at the appropriate times. So if you're in doubt, wash your hands. We'll talk a little bit about proper procedures for hand washing. I know that we all know what the proper procedures are, but I like to just reiterate what we're finding on some of the 2567s, and I'm just say that most of them that we review, there are very few that we find that don't have some sort of hand hygiene citation. So if you are utilizing an alcohol-based hand sanitizer, it is found to kill more effectively and than hand washing with soap and water, and I think largely in part because people are much more compliant. Be very careful. There is a procedure with alcohol-based hand sanitizers, much like washing your hands with soap and water. What we see is people get a little dab of hand sanitizer on their hand and they wipe their hands together a couple times and then they're done. What they're looking for, you should have a drop of hand sanitizer big enough that your hands are moist with that hand sanitizer for at least 15 seconds. They're looking for friction. You're rubbing your hands together. You're getting in between your fingers. You're going around your thumbs, around your wrists, and really focusing on your fingertips, and if you have fingernails, showing that you're having that friction of cleaning underneath your fingernails. Remember that the small bottles of hand sanitizer should not be left unattended on top of your medication carts. You can put them in your scrub pockets. However, with the with all of us going through this pandemic, and we have to be really careful when you're pulling it out of your scrub pocket, you're going to put the drop of hand sanitizer in your hand, put the bottle back in your pocket, and then perform your hand hygiene. That way you're not putting the bottle under your arm after you do your hand hygiene and then putting it back into your contaminated pocket. So just really be conscious about how you are utilizing that hand sanitizer. We've had a lot of questions about, can I leave the hand sanitizer in resident rooms? And the answer is probably not. They do not like those small bottles in there. But I think most facilities now have access to hand sanitizers, if pumps, if not on the walls in the resident rooms, they are in the hallways. A couple of times that hand sanitizers are not permitted would be when your hands are visibly dirty or contaminated. You must use soap and water. You cannot use alcohol-based hand sanitizer if your resident is in isolation for C. difficile. Alcohol-based hand sanitizers do not kill C. difficile. And if you work in the kitchen area, you cannot use hand sanitizers in the kitchen. You can use it in the dining room, passing meal trays, but not back in the kitchen area itself. Washing with soap and water, you can see on this slide, I have put the steps down. I just want to review with you all a lot of the deficiencies that we see around hand hygiene and washing with soap and water. One is people don't do it for the full 20 seconds. So I always say, err on the side of caution. We used to say him the happy birthday song from the beginning to the end once. And as a director of nursing, I walked onto a unit and my staff were singing the happy birthday song so fast because they were in such a hurry that they weren't even washing their hands for 10 seconds. So that's why I say on the slide, hum the happy birthday song from beginning to end twice. Remember, they are timing and watching how long you are performing hand hygiene. So if it's anything less than 20 seconds, they will cite you for not performing appropriate hand hygiene. Err on the side of caution. If you have doubt, make sure that you're doing it at least that 20 seconds. Sing it 3 times if you think you sang it too fast. But just making sure that you do it for at least that 20 seconds. The other citation we're seeing a lot in 2567s is that when they go to dry their hands, they're using that wet paper towel to turn the faucet off. Remember, when you dry your hands, throw that wet paper towel that you used to initially dry your hands, throw that away, then get another dry paper towel and turn the faucet off with that dry paper towel. We already talked about the alcohol-based hand rub. Remember that should stay, you should have enough rub on your hands for at least, it takes at least 15 seconds for it to dry. Personal protective equipment, we all know and are becoming much more familiar with personal protective equipment. Most facilities, you have to wear masks at all times. Throughout your facility. Some facilities are requiring N95 and goggles. Some are just requiring the surgical mask. So putting on PPE, what is the correct order? Remember I said hand hygiene always comes first. So making sure you do hand hygiene before you start donning your PPE. Remembering that PPE should be put on before you walk into the resident room if they're in isolation. Your gown will go on first. Some of the things that we used to get away with, we're not going to be getting away with anymore, right? So when you put the gown on, you want to make sure that it is secured at the neck and at the waist. I am guilty as charged in the past of putting on my gown thinking I'm running in for just a couple seconds. I'll be coming back out. I don't really need to tie it. I'm not going to be in there that long. I get in, the resident wants something else done. Hey, can you change my dressing? Can you do this? And then you end up being in there for a longer period of time. Your gown ends up down around your waist. You're trying to fight the gown and get it up, and now we're contaminated. So they're really looking at, you have to make sure that that gown is tied at the neck and at the waist. The next thing that you put on is your mask, making sure that the mask covers your nose and your chin. Lots and lots and lots of citations right now going on with seeing staff members that are wearing their mask under their nose, or wearing the mask all the way under their chin. I know that they're extremely uncomfortable, but wearing the mask and wearing it properly isn't optional. And we need to make sure that it is at all times over our nose and under our chin. The other thing to remember, if you need to take what my daughter school calls a mask break, you need to make sure that you know where your designated areas are in your facility to do those mask breaks. And typically it's in your break rooms. And you can go there and take 5 minutes if you just have to get it off for a minute, and gather your thoughts and your beings before you have to put it back on and go back and take care of your residents. However, we are now seeing a lot of citations around social distancing, and especially in your break rooms and outside, around picnic tables, and if you have smoke areas and those smoke areas outside, make sure if you are taking your mask off, even in those designated areas, that you are maintaining social distancing, the 6 feet apart. Otherwise, they will cite you for not adhering to the social distancing guidelines and not having appropriate PPE on. Okay, so I've washed my hands, I have my gown on, I have my mask on. Now I'm gonna put my goggles on, and then I'm gonna put my gloves on. When you put your gloves on, your gloves should go over the cuff of your gown so that it's one continuous unit, you're not exposing your wrist. So I went in, I did what I needed to do with my resident. I'm ready to come out of the room, sorry. So I'm ready to take off all of the PPE. And so I'm gonna start with my gloves. Then I'm gonna take my gown off. Many facilities are using, reusing their gowns. So if you're doing that, make a conscious effort not to shake your gown out, but just take your gown off inside out. You're going to hang it or put it in a bag, whatever your facility policy is. After you take off your gown, you'll then take off your goggles and then your mask. Many facilities, if you're required to wear an N95, they're having, at all times, they're having you put a surgical mask on when you go in those isolation rooms. And then as you're coming out, you would dispose of that surgical mask and you would keep your N95 mask on. If that is not the case in your facility, if you went in, let's say you have a surgical mask on, you're going to take it off and dispose of it. Remember, hand hygiene always comes last when exiting the room. Then when you get out of the room, if it's your policy that you have to have the mask on at all times, you'll do hand hygiene again because I've touched the door. And then I'll put another mask on to go down the hallway. Airborne precautions, many facilities do not have true airborne precautions because they don't have negative pressure rooms, but those negative pressure and true airborne precaution rooms are, some examples would be if we were taking care of a resident with tuberculosis. And you would utilize an N95 respirator that is fit tested just for you. Droplet precautions, the resident requires a private room or can be cohorted with another resident who has the same or like infection. For droplet precautions, you would need a surgical or procedure mask upon entry. And remember that when you have someone that's in isolation and you're transporting them somewhere, they have to have PPE on as well. So if it's your facility policy right now, during this pandemic, that everybody have on a mask, then we need to encourage our residents and be diligent about them having a mask on in the hallway. I know it is a battle. Some are more apt to wear their masks than others. Some just, it's really about education and doing our due diligence to make sure that they understand the importance of them wearing that mask when they're outside of their room. So droplet precautions would be an example, would be influenza and COVID-19. COVID-19 is really a transmission-based precaution, which is a combination of droplet and contact precautions. Contact precautions include gloves when in direct resident contact or contact with the environment, gowns, and for our COVID-19, then we would add that with droplet precautions. So when you go into a room that's in transmission-based precautions, you would wear a gown, gloves, masks, goggles, or face shield. Cohorting. Patients should be cohorted depending, if we're talking about COVID, they can be cohorted depending on their COVID-19 status. And those colors can be used on a facility map to help visualize. If you are unsure of red, green, and yellow zones for your facility, please make sure that you know where the red, green, and yellow zones are in your facility. Ask someone, surveyors are asking that question of staff members out on the floor and asking if they know where those rooms are located. So COVID, the red zone, which most of you are aware, is for those that are confirmed COVID positive. Some facilities do have a dedicated COVID unit, and if all members in that unit are confirmed COVID positive, they may continue some type of socialization as long as there's no COVID negative or unknown COVID status in those units. Lately, what I'm seeing in a lot of the facilities that we're visiting is they have, for their red zone, they have just a couple of rooms that they've dedicated at the front of or the back of a unit for their COVID red, and then they have any room can be COVID green, and then any room can be yellow, and they just treat it as an isolation room. So you have to be very careful if your yellow and green units are intermingled, just to make sure that we adhere to those transmission-based precautions for those residents in isolation. So unknown COVID status, or that yellow status, most of you all are still requiring that any new admissions or readmissions are placed in that yellow status for 14 days for observation of signs and symptoms. And you would put someone who you have tested, have done a COVID-19 test on that might be symptomatic, you would put them in that yellow status until that test result comes back. Once that test result comes back, if they are positive, of course, they would be transferred immediately to your COVID red designated area. And if they test negative in that yellow, or those that are on 14-day quarantine and transmission-based isolation, and they don't show signs and symptoms, then they could be brought out to the green area then and out of isolation. COVID green areas, these are the residents who are asymptomatic or not suspected to have COVID-19, or they've had a negative test. Or it can be a resident who's recovered from COVID-19 and they meet the CDC criteria for removing those transmission-based precautions. We want to ensure that we are implementing isolation precautions as appropriate to be safe. And just as important as it is to get isolation precautions instituted, it's also as important that once we know that they are cleared, that we get them out of those isolation precautions as soon as possible. I will say that even on those negative tests, if there remains clinical uncertainty, so if we're doing, if we did a test, it comes back negative, but they're still showing signs and symptoms of COVID, the resident, we would still keep them in yellow status until we could do additional testing. We do have a lot of education and training materials. I have included several handouts in the handout section on the right-hand side of your screen. And some of them, I've included the focused survey, the new one around point of care testing, so that you guys will know the 2 new F tags. It does the focused survey checklist. Please make sure that you're looking through that. It can help you be ready when you get those focus surveys. We are seeing a lot of facilities who might have had a deficiency-free focus survey the state came back in for a complaint survey, and they also did another focus survey for them while they were in the building. So those focus surveys may happen even when they come in for another type of survey into your building. But we do have a lot of resources for you around covering your cough, hand washing posters if you need them, isolation signage if you need it. We have a one-page educational sheet that you can use for residents and staff alike, and families if you wish, on distinguishing the difference. It's a crosswalk between distinguishing the difference between COVID, allergies, and influenza. With the flu season fast approaching, it will just muddy our waters a little bit more. So that it's a great one-pager. If you all are interested, we'll be more than happy to provide that to you. I also included in your handout section a PPE sequencing guide, and many facilities are utilizing those. You can print those out, you can laminate them, and you can put them above your isolation cards. And it's a good reference for not only just your nurses, but if your housekeepers are going into an isolation room, or if dietary had to go into an isolation room, maintenance, some of those other personnel that we have in our facility aren't used to putting on PPE like we are if we're in the nursing department. And sometimes even in nursing, when you're being watched, your wheels fall off. And so it's nice to have that reference so that you can just look at that guide. It's not a race when the State Department of Health is watching you do something. So take a big deep breath, take your time, look at your resources, and if that sheet is right there, you can look at that and make sure that you're doing everything in the right order. So I have, like I said, included some of those handouts, but if there's other resources we can help you with, we're more than happy to send those to you. Now let's change our focus a little bit from nursing to the environment. And we are all responsible for making sure that we are doing effective cleaning in our facility. It's not just housekeeping, but it's all of us having a hand in making sure that we're cleaning and maintaining a standard of cleanliness in our facility. The environmental services in your building does keep logs and schedules on frequencies. So frequency of cleaning can vary: daily, monthly, clean up when it's visibly soiled, when a spill occurs, and some of the deep cleanings they have that are on a schedule. The sequencing of that room cleaning is from you're cleaning a room from the clean to dirty area, no double dipping of the mop head. If you're cleaning an isolation room, it goes without saying that you need to change your solutions before you go to another room to do cleaning. Focusing on those high-touch areas, so bed rails, sinks, doorknobs, toilets, table trays, any of those high call lights, any of those high-touch areas should be cleaned at least daily, if not more. And important to remember in our deep cleaning schedule that our long-term care residents that are with us for an extended period of time still need to have their rooms deep cleaned. One thing that I like to mention here as well, when we are cleaning, please make sure that you know what cleaning agent you need to be using. Make sure that it is appropriate for what you're cleaning it for. If you're trying to kill a certain, if you had an isolation for C. difficile or for COVID, making sure that we're reading that bottle and that there is an indication that the disinfectant that we're using will in fact kill that microorganism. Also making sure that we're diluting the disinfectants according to the manufacturer guidelines, and that we're utilizing it correctly. Many of them will say, put after you dilute it, put it on the surface. It needs to stay wet on the surface for 14 minutes, 10 minutes, whatever it is, and then you wipe it off. So if we're using it and we're wiping it on and wiping it right back off, then we've wasted our time and our solution because we have killed nothing, because we did not follow that manufacturer guideline. Surveyors like to ask for manufacturer guidelines as well as your policy and procedure. So make sure that you're following both of those and that they match. The other thing is when you're deep cleaning isolation rooms, don't forget those privacy curtains need to come down, and the curtain, if you have curtains in the room over the windows, those need to be come down and be laundered as well. Remember that you need to clean, you need to change your solution every day. There has been instances where they get new solution, it's towards the end of the day, they think they'll just save it for the next day. And we can't do that. You need to get rid of it and get new solution. Just a quick example of making sure that we're using the right disinfectant for the right job. In one of my facilities, the CNA was doing a great job. State Department of Health was in our building doing a survey. She was cleaning the shower chair in between her showers. She was doing a great job, except that when the surveyor looked at the disinfectant that the CNA had decided to use, it was not indicated to be used in a resident care area. She had picked up the wrong disinfectant unknowingly, and it was harmful to skin. And so with all good intentions she had, she just wasn't sure what disinfectant to use and picked up something. So again, I can't emphasize enough just to make sure that when we are cleaning an area or disinfecting equipment, to make sure that we're using the right disinfectant. Glucometers is a big tag that we're seeing right now. And if it says that you need to wrap your glucometer in a disinfectant wipe for 5 minutes, then you need to make sure that it's wrapped for 5 minutes. If you pull it out at 4 minutes and 55 seconds, then they're going to give you a tag for infection control. This is one of my favorite slides. It talks about how long organisms can live on the surface if we don't clean them effectively. This really, to me, hits home. C. difficile, if we don't clean it effectively, can live 5+ months on an environmental surface. Staphylococci, 7 months. VRE, 4 months. Norovirus, 3 weeks. E. coli, an hour and a half up to 16 months, which is a huge range. And HIV, days to weeks. We talked about a lot of these general principles, making sure that you clean from clean areas to dirty areas, changing out your cloths in between resident rooms, selecting the right products, diluting them correctly, making sure your spray bottles are all labeled, and getting that fresh solution daily for cleaning and changing it out frequently as you need to. Now, dietary has their own set of infection control things that we still need to be focused on. COVID has been such a big focus for all of us, but we can't forget all the other things that we're still being held accountable for when it comes to infection control. One of the big things for dietary, obviously, is to prevent foodborne illness. And so making sure that we're monitoring the time that we have food out, the temperatures, cleaning the surfaces, hand washing appropriately, and not using hand sanitizer in the kitchen, but using soap and water. Employee illness. This goes for everybody in the facility, making sure that employees and staff are reporting when they are sick. You know, used to, a long time ago, We used to say, oh, you have a sore throat, oh, you're not feeling good, but you feel okay, come on in, take some Tylenol, come on in. You have diarrhea, oh, take some Imodium, come in. We have lots of bathrooms in the facility. Not anymore. If they aren't, they need to know that they need to report when they aren't feeling well all the time. And we need to take extra precaution, especially with COVID as we're going forward. And I know most, I know all facilities that I've been in so far are doing a spectacular job of screening employees as they come to work, and visitors and vendors as they come into the facility. So nice work on that. I know it is an ever-growing task for sure. And then pest control back in dietary. Cooking logs, your dietary staff uses cooking logs, making sure you're recording the temperatures of the food. Food must be less than 45 degrees Fahrenheit within 4 to 6 hours if you're saving it to reuse. If you can't get it below that 45 degrees within that time frame, it needs to be discarded. Using a food thermometer, cleaning it properly before you use it and between your food checks. Cold food should be stored and served at less than or equal to 40 degrees Fahrenheit. And you can cool foods rapidly in shallow pans. You can put ice in that shallow pan and cool your food. Hot food should be stored at greater than or equal to 135 degrees Fahrenheit. But with me saying that, any hot food below 140 degrees Fahrenheit, we should be using that within 4 hours. Heat food rapidly. Please don't try to heat food on a steam table. You can keep it and maintain it on a steam table. Just don't try to get it to temperature on that steam table. Danger zone for food is 41 degrees Fahrenheit to 140 degrees Fahrenheit. Potential food hazards, just those cream-filled or custard-filled items, any cream sauces, meat, poultry, and fish, ready-to-eat lunch meat sandwiches, and foods containing meat, milk, or eggs. I caution people, and we've had a lot of discussion in the facilities that I've done an in-service like this for. Make sure that if you have HS snacks delivered out to the units and they have lunch meat sandwiches or puddings or something like that, they're either being distributed right when they come to the unit, or they need to be labeled and dated and put in the refrigerator in those little dietary kitchens on our units until we can get those out to them. The other thing is if you have residents who maybe are not good at, or don't want to get up early to eat breakfast, or they were out in an appointment, or a dialysis resident who doesn't come back until later, we can save those trays. Just make sure it's refrigerated and we heat it up. But those trays shouldn't be sitting in the resident room or on a counter for extended periods of time before we're serving them to the residents. Dietary just make sure that they're taking that equipment apart and cleaning it appropriately, ensuring that they're logging and having proper temperatures for washing and sanitizing. Making sure that our silver pans that we use, and when they come out of the dish tank, that if they are wet, that we're not stacking them together. It's called wet nesting. And if our surveyors go back there and pull those pans apart and there's moisture and they're wet, then you'll get an infection control citation for wet nesting, because it is a source of bacterial growth. And making sure that our hand sinks back in the kitchen area is free from clutter, so that it's easy accessible for the staff to go back and wash their hands. Just a quick overview of focus surveys. We have been going into multiple facilities, helping them with making sure that things are in place for focus survey. You have the focus survey checklist. I encourage everybody to go through that, making sure that all of your policies and procedures are in place, and making sure that the screening practices at your visitor entry of your facilities, that we have someone there that is doing an adequate job of screening. If there is someone that answers yes to one of the questions, that the person that's taking that knows what to do. So with the focus surveys, we have ramped up here at QSource, and I know that the facilities are doing a lot more education monitoring and screening of practices of staff. Just random observations I would encourage all facilities to do to ensure you see it when you're walking your facility all the time. Is your staff wearing their masks appropriately? When the residents are out of the room, do they have their masks on? Isolation rooms, are the doors closed? Are the staff putting on their adequate PPE when they're in resident isolation rooms? Are they social distancing in your break room if they don't have PPE on and they're taking their meal time? We have done some observation, and just know that everybody in your facility is a potential to get a citation, including your medical directors or nurse practitioners, any vendor in your facility. They should all be adhering to your policies and procedures. So in summary, hand washing we know is the most effective way to prevent the spread of infection. So I can't emphasize enough, wash your hands, and wash your hands again. If you are in doubt if you should be washing your hands, wash your hands. Use the least restrictive isolation possible. So just as soon as it's safe to do so and they meet guidelines, we need to be taking them out of those isolations. Making sure that all your staff know where your red, green, and yellow zones are in your facility. Using proper cleaning agents when cleaning resident and facility environments, and proper food handling to prevent foodborne illnesses. And does anybody have any questions, concerns?
Yes, Kara, we do have a question. It's asking that we address someone who is symptomatic in a yellow area. The impression was that they could leave them where they were and treat them and their roommate as in isolation until the test results came back.
Yes. They should only be transferred to a COVID red area if they have a confirmed positive. Anything else?
A request to please make available the crosswalk.
Absolutely. We will send the differences, that crosswalk out to all the participants. If there's any other resources that anybody is in need of, please don't hesitate to reach out to us. And like I said, we are more than happy. If we don't have the resource, we will get you what you need for sure. Is there anything else, Teresa?
Not at this time.
Okay. Thank you all for joining today. And Tammy, you want to wrap us up?
Certainly. Well, first of all, big thank you to you, Kara, and to all of our participants for joining the call today. The QSource staff is here to help you. And so please contact us if you have any questions about what you've heard today, or if you need technical assistance with your improvement initiative. An additional resource that we have on the slide for you is our Q-Tips podcast for nursing homes. Each one of these podcasts contains great tips for your organization on a variety of topics and things that are really relevant to you during this time. Next slide there, Kara. Remember to visit our resourcehub.exchange site as well. This is our online warehouse of tools, resources, podcasts, and webinars, and all of those items are available to you for free. Now, some do require a registration on the site to access them, but they're all available to you. So if you do need to register, you just simply create an account and you'll have access to more than 1,000 downloadable tools and resources, along with hundreds of on-demand learning opportunities. So just simply type in resourcehub.exchange into your browser to get you started. In addition, we've developed a new resource to help you in conducting virtual meetings, whether those meetings are online or by phone. The virtual meeting guide includes information on software options, how to plan a meeting, how to conduct a meeting, rules and etiquette associated with having those meetings, as well as how to conduct conference call bingo. So all of those things, you can find those on resourcehub.exchange. Now, we do ask that before you leave us today, that you take a few moments to complete the post-event survey. The link is available for you in the chat, and will also pop up as you close the webinar. So just please copy and paste that link into your web browser. We do ask that you complete this. Your feedback is very valuable to us, and it helps us shape future events, future learning and action events. But if you miss the opportunity to complete it, you'll also receive a link later on this afternoon. Also on the slide, you see various ways to connect with us. While we love connecting with you through the webinars, you can also connect with us through Facebook, Twitter, and LinkedIn. Once again, thank you all for joining us. Thank you to our speaker, and everyone, have a great afternoon.